Thank you, Jess, for your speech. We have a great lineup of speakers for you tonight. First, we'll be hearing from Dr. Seong from Alpha Fertility. Dr. Tan obtained his specialist qualification from Royal College of Obstetrician and Gynecologists, United Kingdom. Dr. Tan will be presenting his publication of ERA case with the title of A Successful of Pregnancy in an ERA Patient with a Receptive Endometrium at 190 Hours of Progesterone. Let's welcome Dr.
Okay, thank you, Era. Your name is very fitting for the event tonight. Right. Good evening, ladies and gentlemen. Today I'm going to share two interesting cases from Alpha IVF. Right. So the first one is a case report, a successful pregnancy in an ERA patient with a receptive endometrium at 190 hours. Basically, it's a day 8 of progesterone. Normally, we know that the blastocyst, day 5 is 120 hours, day 6 is 144 hours. But for this patient, her receptivity is at 3 days more than the usual. A little bit of the background. This is a 44 years old lady from Hong Kong. She first came to Alpha Fertility on October 2018. So the diagnosis was made for advanced maternal age and also low ovarian reserve. Previously, back in 2016 and 17, she had 6 IVF cycles in Hong Kong and 2 failed ET cycle. The 2 failed ET cycle were a fresh day 3 transfer and also a thaw frozen day 3 embryo transfer with her own oocyte. When she came to Alpha, she already decided she wanted to use a donor oocyte cycle, right? So she managed to get 7 euploid blastocysts, and she's very happy. And as a clinician, we're also very happy because she has so many euploid blasts, right? However, when we transferred one of the good grade day 5 euploid blastocysts, but she didn't get pregnant the first time. After discussion with her, we proceed to do the ERA, right? And she need the 2 ERA biopsy before we can get the ideal timing for the receptive endometrium. So the first ERA biopsy was done at 120 hours. And after we send the sample to the Igenomix, they recommend us to repeat the biopsy at 168 hours. And we follow through. And when we did the second ERA at 168 hours, then it's still pre-receptive and they advise us to transfer at 190 hours. So 2 months later, we transfer a grade 2 day 5 euploid at 194 hours. I mean, by right, we're supposed to follow the 190 hours, just that sometimes in our operation theater, there are other cases, somehow the timing was also delayed. However, luckily, she was pregnant and managed to deliver successfully at 38 weeks. All right. So this was back in 5 years ago. And actually recently, she already planning for her second pregnancy. So she requested to do the ERA again. And we repeated the ERA at 192 hours and it's receptive. So we are planning to do her transfer in a couple of months' time. This was published by Alpha in Reproductive Biomedicine Online. Right. On the second patient, this is a young patient, 26 years old, African lady, also came to us in October 2008. Her BMI that time was 23.8. She had 2 miscarriages, right? And also she was diagnosed with polycystic ovarian syndrome. In Alpha, she had 2 unsuccessful IUI cycle, and then she proceeded with the IVF cycle. We managed to retrieve 36 oocytes, out of which 24 were matured, and she had 13 blastocysts. 3 went for PGTA. Those 3 blastocysts were all euploid. And we transferred 2 good graded day 5 euploid blastocysts at 131 hours, but she didn't get pregnant. So ERA was recommended. Right. You can see in total, she did 4 ERA before we get the receptive timing, right? So the first ERA, we were using a cyclogest as a progesterone. We did the ERA at 119 hours, but the result came back as non-informative. So the recommendation was to repeat the ERA again. Again, we repeated the ERA at 122 hours of progesterone. Again, the result was non-informative. By this time, the patient and also the clinician were also frustrated, right? So the patient decided to go ahead to do another transfer. But again, the beta HCG was negative. So we have a consultation with Igenomix, and they recommended to use a different type of progesterone, right? So we use a Crenon. We repeated the ERA with a Crenon at 121 hours. It's a post-receptive result. And they again recommend us to repeat the ERA at 97 hours, right? So we repeated the 3rd time. So this time they recommended the time with the timing of 108 hours. We proceed to do the transfer at 108 hours with 2 non-PGTA blastocysts, and she's successfully pregnant with twin and deliver, right? Dr. Nasser, any comments on this?
I have a question, but for the first case, and is what did you think when you received the result, and instead to transfer in a regular time in like 120 hours, you had to do the transfer 60 hours later? Because I would be shocked, right? So how was your first reaction when you received the report?
Okay, by the time, I think we had some experience with ERA, and it sort of give us some good result, right? So, but definitely before we do the transfer, we explain to the patient that her window is a bit out, right? So also at that point, we don't have really high hope, but anyway, the good thing is she managed to get pregnant and deliver, right? So she's happy and we are all happy.
Yeah, and regarding this case, I always say the same. When you have any doubt, just let us know, because we have a team that is working always with this. They are the experts. So then recommendation that may be like change the dosage or change the type of administration of progesterone, they might help to your patients. So please always try to ask to our team, and we will try to help always you and of course your patients.
All right. Any questions from the floor? Yes, all 4 were tested and all within the normal range, within the required range. Yeah. Dr. Navdeep? Dr. Hatta? Before we start the pessary, normally I would do the scan 1 day before we start the progesterone, either cyclogest or Crenon. What do you mean?
But the non-information was actually after the psychologist, isn't it? The ERA.
No, I mean
And-
like in a normal era cycle, we always do the progesterone level before we start on the cyclogest or crenol insertion.
Right.
Right,
Okay,
yeah.
that's what you do
Yeah, yeah,
routinely.
yeah.
Any reason for that?
We want to make sure that the progesterone is not raised above certain level. It's like let's say fresh transfer cycle, we are looking at the progesterone, let's say above certain level, probably the chances to implant is not good, right?
I think it is also required.
Yeah.
So for them to interpret the result. So usually when we send off the sample, they will want the level
Yeah.
as well.
I think it's like we want it because we haven't started any progesterone, so we expect the progesterone level to be low. If let's say already the progesterone level is higher, meaning that the cycle is not properly controlled.
What I'm trying to get at
Mhm.
is that you have no information about the error. Is that the progesterone insertion afterwards is not absorbed, and therefore you don't have the window of
Yeah.
information. So therefore, the blood test for progesterone is probably will give you a bit more information about this funny result. Is that right?
Yeah, I mean,
I don't know. I'm just
It
speculating.
could be one of it could be one test that we could do, but I understand what you mean, but we didn't repeat after the era, we didn't repeat the progesterone level. Yeah, yeah. Dr. Nasser, do you want to comment on that? Yes.
No, what you said, it's right. It's required in order to follow exactly what you did on the mock cycle for the transfer cycle. So it has to be lower than 1 nanogram per milliliter in order that you know the patient didn't ovulate it. Because if you don't control that, then when you make the recommendation and the transfer cycle, maybe you are making a little bit mistake. So this is why it's a requirement. And after that, in my lecture, I want to point out this thing because it's super important to follow this.
So I have a question. I think we all understand why we need to measure the endogenous progesterone before we add on so that they can interpret correctly. So what I was puzzling is that you were recommended to switch the progesterone. Both are vaginal progesterone. So what is the basis for that? Are you suspecting that cyclogest is not absorbed and crenol works better, or what? What is the basis of that recommendation of switching?
Yeah, the probably reason is because they might change the um, the progesterone because it's not absorbing properly, and this is why we are not seeing the results. So this is what we try, and we always have these kind of results. We check our background and we see, oh, we did this time and it works, so let's try to do the same. The day of the biopsy, you mean? We don't do that because we didn't see a correlation. We do know that for the cycles, there's certain levels that say that above of that, there's bad results, so you should cancel the cycle, but we don't correlate with the ARA. But if you need to add more progesterone, what we say is don't do it before doing the transfer because this might alterate the ERA result. So let's do the transfer, wait like 24 hours, and then you start administering progesterone if you need to supplement the patient. But for the day of the transfer itself, or for the day for the biopsy, we didn't see any correlation, and this is why we don't ask for measure the progesterone.
I mean, at the time also, we were thinking whether the patient did insert the cyclogest correctly or not. Maybe when you insert the crenol, it's like the whole crenol is like directly into deeper part of vagina and less prone to the cyclogest from coming out. And in fact, for these 2 times, we did extra intramuscular injection 3 days prior to our era. Right.
Just today, I was reading something related with the patient administration, not regarding focusing in ERA, but in general. And I read that it's about 40% of the cases the patient it's like misleading or whatever you as a physician say. So it's a very high number. We need to pay attention to all of this.
Normally, we don't. Pessary, per vagina pessary,
Vagina
and on the day of transfer, we will give intramuscular
only
progesterone.
one dose of intramuscular.
Yeah. Right. If
Because this is a very good selling point for Merck.
luckily the Merck people is not around, and anyway, we don't have Crinon until next year, right? All right. If no more questions, I will thanks for listening. Yeah.
This one. No, they don't need to hear me.
Oh,
They need to
okay.
hear you. So please use this when you ask a question. Thank you.
Okay, so thank you, Dr. Tan, for your presentation. Now let us welcome Dr. Chong, Clinical Director of SabahCare. So Dr. Chong will share 2 endometrial cases with successfully pregnant patients. Let's welcome her.
Thank you. Thank you, Igenomix, for the invitation. And good evening, everyone. I'm going to share 2 cases here. So my title is ERA and microbiome testing in recurrent implantation failure. So 2 cases here to share. First case is a 35-year-old lady with tubal factor infertility. She started her IVF journey quite early at the age of 27, and she got pregnant in her first IVF treatment, but it was an ectopic pregnancy. Then she had a frozen embryo transfer but failed. And following that, she went to a different center, again not pregnant, and in 2016 went to another center, and it was a freeze oocycle cycle this time, had frozen embryo transfer, again not pregnant. Even though she's young, her embryo development wasn't great. So both cycles from 2015 and 2016, her embryos were enough for only 1 transfer. So by then she's had 3 oocyte retrievals and 4 embryo transfers. And she took a break of almost 5 years. And by the time she came to see me, she's 35 years old. AMH and semen analysis were normal. Again, embryos were not great. We only got 1 blastocyst suitable for biopsy from the 12 eggs we retrieved. And PGTA showed low mosaic. And this time she just wanted to do everything right. So she wanted the PGTA to check the embryo and wanted to check her endometrium. So we planned her for endometrial. We used the hormonal method with oral Proginova to prepare her uterus, and biopsy was done after 5 days of progesterone. ERA results show receptive endometrium, and her microbiome testing was also normal, very beautiful. Emma showed abundant lactobacilli, and Alice showed no evidence of chronic endometritis. So genetic counseling was done because it's a low mosaic embryo. We did a frozen embryo transfer and she conceived, and the first trimester NIPT was normal, and she delivered a healthy infant at 38 weeks. So she had a receptive endometrium and a normal microbiome testing. So it's quite clear that she is going to get pregnant sooner or later. So the main contribution of a success this time mainly come from PGTA that helps to deselect and nuclei embryos. So quite a nice and easy case. The second case is a little bit more challenging. This lady had a first pregnancy at the age of 37 from her first attempt IVF. So 2 years after she delivered, She went on to have a frozen embryo transfers, but all 3 times failed. So she came to see me late last year, and at that time she was 39 years old. Her image was still good. We managed to retrieve 27 eggs, the freeze oocycle cycle, did frozen embryo transfer, and she got pregnant, but it was a delayed miscarriage. She went on to do 2 more frozen embryo transfers, but both failed. And of course, there was implantation in the first attempt with us. But it was a delayed miscarriage. So we were not too worried about the endometrium then, but more of the embryo. So she wanted to have PGTA for her subsequent cycles. And her target is to have 3 children. So between 2021 and 2022, she had 7 cycles. So far, she holds the highest record in my clinic. So out of the 7 retrievals, we managed to get 14 embryos suitable for biopsy. And we finally stopped at the 7th retrieval when we reached her target. So we have 3 transferable embryo. 2 were euploid and 1 low mosaic. So of course, we are feeling confident this time because we are transferring a euploid embryo. But sadly, it failed. So this time, doctor and patient very distressed. So at this point, we discussed about checking the endometrium. So it's time to check the endometrium. So I used the same method to prepare the endometrium with oral progynova. ERA result came back is pre-receptive. So the recommendation is to do the transfer 1 day later, which is 6 days after progesterone administration. And it does state here, a new endometrial biopsy is not required. Her microbiome testing was very abnormal. Emma showed no lactobacilli, and Ellie showed there's evidence of chronic endometritis. So we started her on antibiotics and probiotics. So after treatment, we went on to do the frozen transfer using the recommended time, which is 6 days post-progesterone, and it failed. So this time, I was more distressed than the patient. So scratching my head, what's going on? So we are left with the last embryo, which is a low mosaic embryo. And when we are planning for the transfer, the treatment was interrupted by episodes of irregular spotting, and her endometrium also started playing up. We just couldn't get the thickness that we wanted. So I would say out of desperation, I changed the protocol. So I used a long down regulation protocol and finally managed to get a more reasonable thickness, just above 7 millimeters. And at this point, assuming that the endometrium receptivity could have reverted back to normal after antibiotic treatment, so I did a transfer using the standard time after 5 days on progesterone, and she's pregnant. So just last week, she came for review. She's doing well. Scan showed a single viable fetus at 10 weeks. Fingers crossed. Right, so two points for discussion here. Firstly, chronic endometritis and ERA testing. So it's been reported that chronic endometritis may change the individual window of implantation, and in the presence of chronic endometritis, ERA results do not match the exact timing of the personalized embryo transfer. Just sharing an interesting case reported by Ota et al. In last year. The title is A Case of Discrepancy Between 3 ERA Tests in a Woman with Repeated Implantation Failure Complicated by Chronic Endometritis. So the author concluded that endometrial samples with chronic endometritis did not yield the recommended time of implantation in ERA. It's better to perform chronic endometritis test at the same time as ERA, and if chronic endometritis is diagnosed, ERA testing should be performed after treatment. And just a few words on recurrent implantation failure. Just 2 weeks ago in this online congress, Dr. Nasser, you had a very interesting debate with a speaker from Taiwan. I really enjoyed it. I think both of you did agree that ERA is not for all, but maybe more for those with recurrent implantation failure. You also mentioned that it's just so difficult to do meta-analysis because of all the discrepancies between studies, for example, progesterone level and so on and so on. And to me, for a start, even the definition of recurrent implantation failure varies. Some takes 2, some take 3 transfers. And this ESRI came out with this good practice recommendation just this July. The recommendation is on patient with RIF and needs to be investigated. So they even divide it into transfer of euploid embryos and transfer of embryos of unknown euploidy with the age breakdown. So to me, endometrial implantation is just so complex and it's a mystery yet to be solved. Yeah. So I look forward to more discussion after this. Lastly, if Dr. Nasser, if you're planning for a vacation, please consider coming to Sabah. We are not far from Kuala Lumpur. Thank you very much for all your kind attention. Any comments from the floor?
Thank you for the presentation. I know that this is not the topic for today, but as far as you were talking about PGTA, I would like to emphasize the importance and also looking at the results with low mosaics, because we are having more and more evidence that low mosaics has a good prognosis, reproductive prognosis. So we shouldn't discard them. For instance, in Spain, October 1st, we start reporting to all the clinics from 30 to 50%, we are talking about low mosaic, for 50 to 70 high mosaic. Before, the clinic can decide if they want to report or not. So after 30%, if they don't want to report mosaics, we will call it abnormal. But after the guidelines from the PDIS, that next year is going to be here actually, we cannot do this anymore. Obviously, everyone wants to transfer a euploid embryo, but you show us how transferring a low mosaic embryo after always genetic counseling can get pregnant the patient, and not only pregnant, but have a healthy boy.
Yeah, yes, definitely. So, we shouldn't, label these embryos. So they are all with a good potential.
Thank you.
Yes, antibiotics and probiotic, because she has 0% of lactobacilli. Yeah. I use all sorts. Well, antibiotic is just the simple augmentin, and probiotic is whatever my pharmacist gave me. So it's Gynoflor, vaginally, and probiotics, oral probiotic.
And for a week, is it?
No, augmentin for a week, but the probiotic is just carry on until her next
But interesting
transfer.
enough, the last with the low mosaic, you did not do any ERA or EMA or at least, and she got pregnant.
You mean, sorry?
The last.
Yeah, so I did not repeat the ERA. Probably I was like strictly following the instruction. It is to transfer 6 days and you don't need to repeat. But just assuming that the antibiotic probably has done the work. Yeah. But if according to the paper from OTA, they did recommend to repeat the ERA after treating the chronic endometritis, which we didn't do, but I just assume it has reverted back to normal.
Would you say that because of endometritis can shift the receptivity status, then would you say that it would be recommended that we do all 3 tests?
I would.
Thank you for dinner.
This is something that we are investigating. Actually, if in my because we are seeing who's first, the chicken or the egg, right? And we don't know for sure. And actually, our recommendation is the opposite one. Why? Because the ERA window of implantation usually don't change unless we have a body mass index that rise super quick, or if the patient has a surgery, then we recommend to do it again because maybe the transcriptomics of the endometrium changes. But we do know that from cycle to cycle, the microbiome might change. And this is why if we have to do it separately, of course, it's better to do it all together. So you have all the information and you can make the transfer later on if you don't have anything, or if you treat the patient, you can do the transfer. But if you have to do one first and the other one in another cycle, so far until we have more results and more research, we do recommend to do first the array and then do the part of the EMA analysis.
Thank you.
Hello. Thank you, Dr. Chong, for the presentation. Next, we'll be hearing from Dr. Helena from KL Fertility. Dr. Helena is fertility specialist and consultant in obstetrics, gynecology, and director of KL Fertility Center.
Good evening, everyone. I know that a lot of you came from a long way. I did because of a traffic jam. Now today I'm just going to touch base on 3 cases of the ERA, which I've done on my patients, which I found rather interesting. So let me just share this story with you. Now, of course, I did a little bit of reading, and I know that our successful outcome of our IVF rely both on the formation of chromosomally normal embryo and its implantation in a receptive endometrium. Now, we also know that every 3 in 10 women have a displaced window of implantation. Now, of course, we all know this very famous study by Carlos Simons, which shows that, yes, ERA is actually very useful in his group of patients. Now, his study have very shown that the pregnancy rates has been improved if you have a personalized embryo transfer. However, there are now studies that shows that routine endometrial receptivity array in first embryo transfer cycle does not improve pregnancy rate. So where do we stand in this? Okay, now there is also another very recent interesting paper that came out from China that look at 281 Chinese women with recurrent implantation failure, and they actually show that there is actually benefit of ERA in this group of patients. Now, I also did a bit of reading on a review on various meta-analysis on ERA, and it does actually show that if we actually routinely do ERA on all patients for who are going through IVF, it doesn't seem to actually confer any benefit at all. But in patients with recurrent implantation failure and also in patients with adenomyosis, there seems to be a benefit in using ERA. Okay, so that is actually the conclusion of this review article. Now, coming back to my 3 patients, let me just introduce you to Madam TEY, a para 0+3. She's actually rather young at the 32 years of age when she came to see me. She had a polycystic ovary with irregular cycle, and she unfortunately had 3 miscarriages, one after another. Husband's sperm analysis was normal, and the couple have very normal karyotyping, and all other screenings were negative. So obviously, she read about IVF, she read about PGTA, and she said that, my miscarriages must be due to abnormal embryo. And please let me have an IVF. I want to see that what is wrong with my embryos. So here, lo and behold, she had an IVF. She had 8 blastocysts, 4 were biopsy, and 4 was vitrified without biopsy. And those embryos, which was biopsy, will all turn up to be euploid. So she was very happy. Her first frozen embryo transfer was done in June 2019 with a very nice grading euploid embryo under HRT cycle. But she did not get pregnant. So we scratch our head. We say, what else to offer to you? So we said, hey, there is a new test called ERA. Would you like to, try ERA and see whether there's some issues here? And lo and behold, we did an ERA test, and the result came back as 109 hours as her window of implantation. So we look at the result, we say, well, that's what the test tells us, and let's go for it. And we follow the personalized embryo transfer, and lo and behold, she got pregnant and deliver a healthy baby via cesarean section at 39 weeks with a birth weight of 3 kilo. And this was a little child that came and visit us after delivery. So there we go. Now, in February 2022, she came back again and said, I got plenty of embryos sitting here. So I would like to have my second baby. And what should I do? Should I repeat ERA test? And should I not? So we looked at the, so we rang up Igenomix, and you guys said, well, it may be valid. So let's go for it. Let's not do a ERA test anymore. So I went on and followed the 109 hours, and lo and behold, she got pregnant again with another euploid embryo. And she then delivered a healthy baby boy at 39 weeks via cesarean section. So there we go. Now, so that goes to illustrate that actually ERA test does stand the test of time. So meaning that the ERA test was actually, the two pregnancy were 3 years apart, and following, the ERA which was done 3 years ago. Now, let me also draw the attention to case number 2, Madam TSW, who again came to us at a young age of 34 with 3 miscarriages. Okay, again, husband's sperm analysis was normal. And again, her karyotyping was normal. Everything else is normal. Now, in November 2018, she has an IVF and PGTA. And 11 eggs were collected, 7 fertilized, and 3 blastocysts were biopsied. And it all turned out to be euploid. Okay, so where is the problem now? So in the first frozen embryo transfer in February 2019, we actually gave a euploid blastocyst back and under natural cycle. And she did get pregnant, but the beta HCG actually dropped quite rapidly after it went up and came down within a week or 2. So the second frozen embryo transfer, again, we gave her a single euploid blastocyst under natural cycle again. And this time, she didn't get pregnant. Now, of course, we were all very embarrassed and we were all very shocked, okay? We thought that the euploid embryo would definitely get her pregnant. So what did we do? So we scratch our head and say, why not? Let's try ERA and see what the ERA tells us. So we did an ERA, and the ERA result came back of 123 hours. So we thought that, well, that's the only thing that we can find. So let's try and see what happened. So during the third frozen embryo transfer, we actually did the embryo transfer under HRT cycle, which is personalized embryo transfer. And she did get pregnant, and she delivered a healthy baby boy via cesarean section at 39 weeks. And the birth weight was 2.79 kilos. Now, let me also give you another case, which is Madam KSM. She's a slightly older woman who comes to see me at 38 years of age. No pregnancy in the past, but she has very low AMH. And the husband's sperm was atrocious. She has her first IVF done in September 2019. 1 egg was collected and there was no embryo because the egg was really poor. She has a second IVF done in November in 2019. 3 eggs were collected, 2 mature eggs, 1 fertilized, and she have 1 day 3 embryo. Now she said that, look, I have only 1 embryo and I have such low AMH, all right? So I would like to actually do embryo banking. All right, we say, well, lo and behold, let's go for it, okay? So the third IVF was done in March 2020. She has 6 eggs collected, 5 mature eggs, 5 fertilized, 2 day 3 embryo, and 2 blastocysts, which is a remarkable improvement from her first and second IVF. So at this point in time, she has already had 3 day 3 embryo and 2 blastocysts. And we said, well, time to move on. Go on, have your embryo transfer then. So her first frozen embryo transfer was done in May 2020 with a HRT cycle because she has very irregular cycle. And she has 3 day 3 embryos, which was tall to day 5 because we wanted to actually pre-select the embryo. 2 blastocysts was formed. 1 was re-vitrified And one very good great embryo was transferred, and she wasn't pregnant at all. So second frozen embryo transfer subsequently, also we tore two frozen embryo, we had two frozen blastocysts, and we tore both of them, and we put it back, and again, she didn't get pregnant. Now I'm only left with one frozen embryo blastocyst, which was frozen. So after a long discussion, you know, when patient is distressed, the doctors are equally distressed. Okay. So what happened is and so she decided that she wanted a PGTA this time. So she had her fourth IVF in January 2021. 4 eggs were collected, 2 mature eggs, 1 fertilized, 1 blastocyst, which went through PGTA, and it came back as euploid. At this time, I wasn't going to let her go. I say, please do your ERA test and see what's going on. You know, you have 3 very nice looking embryo put back, and this time you have spent so much money as well as a PGTA. Let's see what happens to your endometrium. Is there something wrong there? But she refused. So she went on to have her third frozen embryo transfer in April, and she had her euploid embryo transfer, and she did not get pregnant. So she come back crying, of course. And what else can we offer? Yes, let's do an ERA test for you. And strangely, the ERA test came back as 92 hours, and it's 1 day earlier than the time which was performed. And the recommendation is to perform a new biopsy. At that point, this patient was totally fed up with me. She's fed up with everyone on earth. Okay. She said, no, I'm not going to have another endometrial biopsy. I have no more money. Okay. So transfer back. So with that, I follow that timing, 92 hours. And lo and behold, she got pregnant like magic. Okay. And she delivered a healthy baby girl at weighing 2.89 kilo. And that's the little baby that we had in our hand. So all these 3 cases have clearly illustrate, the special group of patients that would benefit from an ERA test. With that, I thank you very much for your attention, and I'm open to any discussion or any questions. Yep.
I would like to make a couple of comments. First one is the case 1, just to reinforce your idea about and we were discussing earlier that when we have an ERA that is displaced and we make the transfer, patient gets pregnant and deliver a baby, and after 1, 2, 3 years apart, and you don't need to repeat it, but the recommendation is always ask the team. Why? Because we are always improving the algorithm and having better and more accurate results. And this is why it's important to ask. They told you, no, do it at the same time. That's perfect. But always please ask, because maybe we decide to do in the other way. And in case 3, it's also nice because we only ask for a second biopsy in less than 10% of the cases. But we do that because the probability that the patient is going to be receptive at that time is lower than when we recommend directly to make the transfer. This is why we do recommend to do a second biopsy. But you did great as well. If the patient doesn't want to make the second biopsy, let's go for the timing that we were asking the second biopsy. So really nice cases. Thank you.
Thank you very much. Okay, thank you very much.
Thank you, Dr. Helena, for the great presentation. Finally, we'll be hearing from Dr. Nasser, Genomics Academy Scientific Director. So he'll be sharing his extensive experience with ERA and the upgraded Emma Alice microbiome test. Let's welcome Dr. Nasser.
Thank you very much. I don't know if I move my hand, so I prefer to have it in here. Well, first of all, thank you for having me here and thank you for attending. I don't know what to say after those fantastic cases. You did all the jobs, so we can have some drinks in here maybe still. But anyway, as far as we are in here, let's do a start. And it's a good thing that you already mentioned the hot points, because ERA has been for the last 10 years in the field. So this is why I'm not gonna do the typical lecture starting point with the first paper and then how many genes are we analyzing and anything else. So my point is just to go for what are the key points relevant that you already mentioned, some of them, in order to have good results with the ERA. And we don't know that there are several conditions that might affect or know the implantation of the embryo at the endometrium, such as the endometrial microbiota, maternal embryonic crosstalk, the residualization, and of course, the endometrial receptivity. And this is the first part of my talk. I'm talking about the endometrial receptivity. And just as a brief introduction, as far as you know about how it works, we do know that most of the patients will be receptive at timing 120 hours after first intake of progesterone or day progesterone +5. But we do have some of them that will need 1 or 2 days more if it's pre-receptive, or they will need 1 or 2 days less if it's post-receptive. So let's go for the clinical considerations. And those are the important points that we need to follow in order to have good results. First one, important, you mentioned, all of you, recurrent implantation failure. So we do need to analyze the correct population, because the ERA test is indicated in patients with recurrent implantation failure, where the rest of the factors, such as the chromosomal status of the embryo, are ruled out, because it's in this population in which there's a greater risk of presenting a clinical relevant displacement. And I like to show these different stages, the receptivity, pre-receptive, late receptive, post-receptive. But you know, and there was a paper published in 2020 by Wang saying that this is not the reality, but this is. So we are not changing a stage by stage, but this is something gradual. So, and I will repeat later on, having a patient that is non-receptive, it doesn't mean that the patient cannot get pregnant. But the thing is that if I have a patient that is pre-receptive in this part, even though if I don't perform the ERA, it's more than probable that when I make the transfer, the patient is going to be receptive at the timing of the implantation. The other point is that most of the patients without recurrent implantation failure that are pre-receptive are going to fit in this part that I was mentioning before. So this is why in most of the papers, they are not showing benefit for this kind of patients. Why? Because probably they are going to reach the receptive stage when the embryo is getting implanted. Meanwhile, the patients with recurrent implantation failure, most of them, when they are pre-receptive, they are going to fit in here. So we do need to transfer later on in order that they get the receptive stage. You also mentioned, we were talking about the measurement of the endogenous progesterone. Is super important to do that. We have to control and has to be below 1 nanogram per milliliter in order to be sure that this is not going to affect the results. And also proper control over reproducibility in number of hours and protocol, dosage of progesterone, way of administration. So we have to mimic same thing that we did for the mock cycle in the transfer cycle. And this is important. And later on, we would talk again, because some of the papers published didn't follow instructions. And again, I talk about the probability of pregnancy. We know that with the ERA, the goal is to increase the probability of pregnancy. And I put an example in here. We have a patient that performed the ERA and it was 1 day pre-receptive. So we will recommend to the patient to make the transfer 24 hours later because she's going to be at the receptive stage. But what happens if we have the same patient and we don't analyze for the ERA? So more than probable, we are going to make first transfer and the patient is not going to get pregnant. Second one, with the same results. Then we will have a third endometrium transfer and patient probably is not going to get pregnant again. And maybe, and only maybe, and the fourth one, and by chance, we do know that the embryos has different morphokinetics, and maybe this one goes and develops slower. So at the time when that embryo is going to get implanted, the patient is a receptive stage. So this was I was mentioning that a non-receptive patient has not 0% chances to get pregnant, but we do know that has lower chances. And in this case, and it's just an example, it took like 4 times in order to get pregnant the patient. So we do know that there's several papers published for the ERA, and also some of them, and lately, that are telling us that, well, it looks like that the ERA is not working. And I'm going to explain some of them in favor, and I'm not going to explain the ones that are against, but I'm going to tell you some tips regarding some of them. And we can discuss later on if you want. You already mentioned this paper study patients with recurrent implantation failure, 281, just as a summary, say that the implantation rate in the regular frozen embryo transfer was 20% versus 42% in those patients when we transfer in that personalized embryo transfer, when the ERA is telling us that the patient is receptive. Pregnancy rate from 39 to 63%, and clinical pregnancy rate from 25% up to 50%. So the authors concluded that offering the ERA to patients with recurrent implantation failure, again, we are talking about indication, can be effective, improving implantation and pregnancy rates compared with the conventional frozen embryo transfer. And we were talking about systematic review and meta-analysis. I'm going to present a couple of them that they look almost for the same. This was published in 2022 by the group of Liu, and they did 2 different arms. The first one is good prognosis patients. They call good prognosis those ones from 0 to 2 prior failed frozen embryo transfer with and without ERA. And a second arm with recurrent implantation failure, poor prognosis patient cohort. All of them performed ERA, and they wanted to compare those that were non-receptive and did it personalized embryo transfer with those ones that were receptive and did a conventional frozen embryo transfer. So first result, from 0 to 2 good prognosis patients, you can see that even though it was almost 15% superior in the arm of the ERA, the reality is that there was not statistically significant. So for the authors say that good prognosis patients, maybe the ERA is not helping. But we already demonstrate that with the paper from Dr. Carlos Simon, that's saying that even though we demonstrate that it was 14 percentage points better personalized embryo transfer than fresh transfer, and 11 percentage points better to do and personalized embryo transfer than frozen embryo transfer, we didn't reach the statistical significance. So this is the same thing that we were telling. But when they arrived to patients with poor prognosis, comparing non-receptive and receptive, the authors say that we were mimicking patients non-receptive when we move the window of implantation and make the transfer accordingly with those ones that were receptive. That means they didn't have any problem with the window of implantation. So at the end of the day, what the authors say to us is that the use of the ERA in recurrent implantation failure helps to have similar results to good prognosis patients with or without ERA. So we are helping these kind of patients that are the patients that are making our lives harder, right? And on the same point, this year in Human Reproduction 2023, the group of Damian Glujovsky presented similar results. So they did exactly the same. Poor prognosis patients, good prognosis patients. So again, for good prognosis patients, they didn't find any differences in between the ERA and no ERA. One, when they came with the bad prognosis patients with recurrent implantation failure, they say that in these patients, it suggests that the personalized embryo transfer might improve the clinical pregnancy rate. So again, indication, indication, indication. This is the abstract that we presented this year at Hsuen in Copenhagen from our group, talking about the clinical impact for the transfer guided by the ERA in patients with one or more failed transfers. And you can see here that we are talking one or more. And again, what is the meaning of recurrent implantation failure? Is one, is two, is three? We are exchanging all the time, and you ask one physician, you ask another one, and we all have different results. And the reality is that for me personally, probably would be after 2 failed embryo transfers. But sometimes at the clinic, the patient that suffered a one previous embryo failed transfer, they don't want to go to a second one without doing anything. And this is why sometimes we have to tell them, okay, we have these opportunities. Probably you have to wait another transfer, but patient is going to say, no, I want to make it now. And this is another problem that we are facing when we perform research. You tell the patient, okay, I'm going to do the ERA for you. If you go to the arm for the ERA, I'm going to transfer you accordingly to the ERA, but could be that you go to the control group and the patient say, no, I don't want to do that study. So this is the problem that we are facing also when we do research. So, well, what we presented in the SRE is that the pregnancy rate for the standard conventional embryo transfer was 45% versus almost 60 pregnancy rate in personalized embryo transfer, ongoing pregnancy rate 33 versus 43%, and live birth rate was 32 versus 42%. All of this statistically significant. We took this data and we put another thing into the equation, that is the PGTA. We do know that more or less the importance of the embryo is around 80% in the success or not of the pregnancy, and the endometrium could be like 20, 25%, depending on the cases. So this is what we would like to do. We took from those patients, those one that went to a PGTA cycle to remove the chromosomal status of the embryo from the equation, and this is what we obtained. And this is internal data unpublished that we would like to publish, but we didn't yet. And you can see that the pregnancy rate was 37 versus 65 doing personalized embryo transfer. Ongoing pregnancy rate was 27 versus 49, and the live birth rate was 26 versus 48%. Again, all of this being statistically significant. So it's true that we are lacking of recurrent implantation failure studies for these things that I'm telling you that patients don't want. We are not recruiting, and it's really hard. But we are conducting right now a multi-center prospective non-selection study for those kind of patients with a previous implantation failure. The idea is to have the patient with a stimulated cycle with PGTA. So again, we remove the chromosomal abnormalities from the equation, and we are going to do the conventional transfer without disclosing the ERA result. So then if the patient gets pregnant, we will do the follow-up. But if the patient doesn't get pregnant, we will disclose the result of the ERA, and we will perform the transfer accordingly with the ERA, or we will perform a second biopsy if needed, and then the transfer accordingly, and then we will check all the results. So then having this non-selection, we hope that we will clarify that we need to do this kind of test, or we can offer this kind of test for our patients with a recurrent implantation failure. So again, I said before, we do realize that there are some papers published that are telling or claiming that, okay, ERA is not working. However, first thing, population analysis. So in those studies, there's no recurrent implantation failure patients. And again, we know that from 2020, from the RCT from Dr. Carlos Simon, ERA is not for everybody, but we have to do education and indication. Recurrent implantation failure, you mentioned about adenomyosis, because we do know that patients with adenomyosis has higher chances to have a non-receptive endometrium. This is why would be a good indication. Same thing with patients with atrophic endometrium, less than 6 millimeters. We do know also that it's higher the percentage of non-receptive patients in this kind of atrophic endometriums, and this is why it could be also a good indication. And same for obese or extreme obese patients, because also we observe that the non-receptivity is higher than the other patients. Also, because they had a retrospective analysis bias, obviously, when we do retrospective, could be certainly biased, and this is something that we all know. We talk about that we have to monitor the different variables, talking about endogenous progesterone. There's one of the papers that it's very famous, the one published in JAMA from Doyle, that they, in the material method, say that they were doing less than 1.5 nanogram per milliliter, so they don't follow the instructions, or at the physician discretion. So this means that what could be below 1.5, or we don't know for sure. And again, I'm going to repeat this: probability of pregnancy. A non-receptive patient has lower chances to get pregnant, but it's not zero. If you get a patient that is non-receptive, but it's almost in the receptive stage, and you transfer without ERA, more than probably is going to get pregnant. So you will say, oh, I don't need the ERA because this patient, even if non-receptive, is getting pregnant. It's not 0%, but has lower chances that we know. So when reviewing publications, we need to keep in mind these above 4 points, and then rationale the data presented, and weigh properly the results from clinical trials versus opinions. And I always talk about the scientific innovation phases. For every new tool that we have in our field, in another fields of medicine, of the technology, I'm talking about the ERA, and we do know that at the very beginning, we are at the panacea, right? Looks like that the ERA is going to work for everyone. We went on TV, prime time in the US, and all the patients were crazy about it, but we do know that this is not the real. Then you go to the harmful health. Looks like that the ERA doesn't work. So stop doing that, right? But at the end of the day, we have the consolidation period and the reality. The reality is that we need to indicate the ERA for those patients that are going to get benefit of it. So let's move to the second part of the talk today. And I'm glad that you also talk about the microbiome, because we do know also that it plays an important role into the implantation of the embryo. And we do know that in the medicine books, they was always said that the uterus is an sterile organ. There's nothing there, but we do know now that this is not real. And starting the NIH project in 2007, the Human Microbiome Project, they wanted to map a healthy person, mapping different areas of the body, such as the airways, the skin, the oral part, the gastrointestinal, and also the one that is more interesting for us, the urogenital tract. As you can see in a healthy person, the most abundant genus is Lactobacilli, and you will hear about me all the time talking about Lactobacilli. And just a brief introduction, humans have 10 times more bacteria than cells living in our body, that those bacteria are especially abundant in the skin and the digestive tract. For instance, in the endometrium, we only have around 9% of all of the microbiome in our body. In a person weighing 70 kilograms, 1 kilogram more or less is due to a bacteria cohabitant. And between 20 and 60% of these bacteria, depending on the location, are not cultivable under standard laboratory condition. And this is important because me as a lab person, I would believe if I grow something and I find it there, it's because it's there, right? But if I'm missing this huge part of the microbes, then I can be missing information. We do know also that the microbiota is a continuum on the female reproductive tract. You see the different parts of the tract has different amount of bacteria, but all of them has bacteria. Again, in the endometrium, the most abundant is the Lactobacilli. And it's a reiterative question that what we are doing the analysis on the endometrium, if we can go for the vagina, that is less invasive. One of the reasons is because we find a lot of coincidences, but also differences. You can see in the first paper from Caroline Mitchell in 2015 that they found bacteria in the endometrium that they didn't find in the vagina. And we published the same in 2016, our colleague Inmaculada Moreno. Those bacteria were found only in the endometrium, and we couldn't find it on the vagina. So they are so similar because you can see here that they are so similar, but at the same time, they are different. And this is why we are checking for the endometrium. And there's another groups like Tao and Kiono that they were demonstrating as well that the most abundant genus on the endometrium is the Lactobacilli. And this was the first paper that I mentioned before from our colleague Inmaculada Moreno. We do know that this was kind of pilot study because there were limited amount of embryo transfers, but we placed a cutoff in a 90% of population of lactobacilli. So we call patients lactobacilli dominant microbiome, those ones with 90% of population of lactobacilli or above, and non-lactobacilli dominant microbiome, those ones that were under the 90%. You can see the results. Pregnancy rate per embryo transfer, 33 versus 70. Implantation rate per transfer, 23 versus 60. Ongoing pregnancy rate per transfer, 13% versus almost 60%. Live birth rate per transfer, 7% versus almost 60%. All of this is statistically significant. It was not the miscarriage rates, probably because the number, although it went from 60% in non-lactobacilli dominant patients to 17%. And we observed at that point also, again, the importance of the lactobacilli, because in the live birth, you can see how was the population versus when the patient had a miscarriage or an implantation failure, when the lactobacilli is lower and there's another pathogens that are higher. In this case, Gardnerella, for instance. And let me show you this, that was a case report, but we can see that the different microbiota in the same patient. It was a patient with primary infertility, one cycle of IVF that fails. Then she went for another cycle with 13 fertilized oocytes, 10 blastocysts, 6 of them were euploid. Okay, so patient went for 2 frozen embryo transfer of euploid embryos, and the beta was negative. She didn't get pregnant. And the next cycle, we did the ERA, and we took also for the analysis of the microbiome. But at that time, the microbiome was under research, so we didn't use it for any purpose. We did a transfer of the 2 euploid blastocysts more, and with the personalized embryo transfer by ERA, and the patient got pregnant, but at the 8th week of gestation, she had a miscarriage. Then we did also the POC to properly check that the miscarriage wasn't because of chromosomal abnormality, even though we did it at PGTA, and it was 46XX from fetal origin. And then we performed another collection for the microbiome, but later on, we did realize that at that point that we collect the fluid for the analysis of the microbiome, the patient was pregnant already, 4 weeks of gestation. We were so scary to think, maybe we could impair the development of the fetus or something. But the good thing is that the patient had a healthy boy. And after that, we were curious to check the different profiles of that one when the patient was pregnant, 4 weeks of gestation, and the other one when the patient after that had a miscarriage. And you can see the completely difference. Patient when was pregnant and the patient when had a miscarriage with lower chances of lactobacilli and more bacteria and pathogens that could affect and had this provoke this miscarriage. But I said before, we published the first paper in December 2016 with Inmaculada Moreno, like a pilot study. And then we increased the number and published this paper in 2022. And at that time, it became this kind of guidelines in the human reproduction, talking about the methodological recommendation to do studies on the microbiome, such as type of controls, type of samples analyzed, collection of storage of samples, preservative used for preservation, data analysis, validation, and presentation. And the good thing is that we did follow all of them in our research. And then we published the paper with a total of 452 patients. So those were the different participant sites. Maybe some of them are, you know about them, right? Different ethnicities, that it's also important in order to know that this is working for all different ethnicities. And the summary is that with those 452 patients, we performed ERA to eliminate from the equation the part of the window of implantation. So we were always transferring the patient when she was receptive. And then we got the results, 58% pregnancy, 42% no pregnancy. And for those 58% pregnancy, we had 41% live birth rate, and then 8% biochemical and miscarriage, under 1% ectopic pregnancy, and again, 42% no pregnancy. And we correlate this with optimal microbiotes on pathogens and the different results. And also, to do a summary of the paper, we found some of the bacteria that were increased in poor outcomes compared to live birth. So in those patients with poor outcomes, we observed Atopobium, Bifidobacterium, Gardnerella, Klebsiella, Streptococcus, and so on, all of this. On the other side, we observed decrease in poor outcomes compared to live birth, again, Lactobacillus, but also Micrococcus, Cupravidus, Enterococcus, and so on. So some of the bacteria were higher and some of them were lower when we obtained poor results. And the good thing also, and this is something that we are developing for our new way to understand the microbiome, is that we put a normal range. This is the normal range. What this means? The patient can have a pathogen, but at the end of the day, if the patient with this pathogen get pregnant and have a live birth, then it doesn't matter. So this is what we did. For all of the pathogens, even Gardnerella or the rest, we put in a normal range. So we can tell you, okay, your patient is positive for Gardnerella, but is on the normal range. So you don't need to treat the patient. You can go ahead. And this is the good thing and what we are improving right now with the test. So just a summary of the results, we do know that the pathogenic profile is associated with all of these bacteria or pathogens. Patients with a higher abundance of lactobacilli are more likely to achieve reproductive success. Endometrial microbiota should be considered as possible emerging cause of implantation failure and or pregnancy loss. And we observe at Hsuen, not this year and the other one also, that there's increased interest in those kind of tests. And the endometrial microbiota composition before the embryo transfer could be a useful biomarker, considering offering an opportunity to further improve diagnosis and treatment strategies. So let me show you this paper from Dr. Iwami, that it was super interesting because they had 200 patients. They offered to do the EMMA test to analyze the microbiome. They had a percentage of patients, in this case, 64 patients, that they don't wanted to do it. So they went to the embryo transfer, and then 121 that went to do the EMMA analysis. We had 67 with a normal result, so then they went for the embryo transfer. We have 44 with a mild dysbiosis or ultra-low biomass, so we provide probiotic treatment and then go for the transfer. And we had 30 patients that become abnormal result for the EMMA, so we did antibiotic treatment, probiotic treatment, and then we went for the transfer. So for those 30 patients with an abnormal microbiota in the first biopsy, of course, we did the personalized antibiotic treatment. After that, the probiotic. We were able, in a second biopsy, that we observed that 75% were cured, that it was a good proportion. And I will show you later on data with a higher numbers. But the thing is that with a second biopsy, still 25% that were abnormal, either with the same pathogen or another one. This is the importance that when we have a patient with a positive for chronic endometritis or another infection, we always do recommend, strongly recommend to do a second biopsy, because we need to be sure that we remove the pathogen and we are going to do the transfer in the better conditions for the patient get pregnant. So if you can compare the results, pregnancy outcomes after the first frozen embryo transfer, control group without ERA, and the group when we perform the EMMA and then the intervention, you can see that the clinical pregnancy rate was 12% versus 42%, ongoing pregnancy rate 9% versus 33%, early miscarriage rate was 25 versus 20. This was not statistically significant, but live birth rate and the rest, it was 9% versus 33%. If we go further and we check the pregnancy outcomes after 2 cumulative frozen embryo transfers, you can observe also the differences between the control group and the intervention group. You can observe the implantation rate from 33 to 48, clinical pregnancy rate from 33 to 64, ongoing pregnancy rate from 32 to 48, and then also the live birth rate from 31 to almost 49%, all of these being statistically significant. And also, importantly, we observed the week of gestation for single birth, it was also statistically significant in between the both groups, because a microbiota that is abnormal is not only affecting us as a reproductive medicine field, but also for the obstetrics. We have preterm birth and things that can affect to the obstetrics outcomes. So I was talking about that we are improving, we are changing technologies, and we started in 2018, and we use NGS because we didn't know anything about the microbiome and the endometrium at that point. So we need to screen everything to know what's going on and the endometrium in a patient. So since the launch, we have analyzed more than 70,000 clinical samples, and as a reflection of our experience by the NGS, we know which bacterial pathogens are most frequently detected in the human endometrium. After all of those samples, we do know exactly what are the bacterial pathogens that most frequently are detected in the endometrium. And based on this data, we design a precise and complete panel that is a target panel that contains up to 98% of the bacterial pathogens detected with the NGS. All bacteria included in this panel are clinically relevant, and most are identified as a species level. So we are going one step ahead. So before, we were recommending a treatment with antibiotic, but now we can focus in a little bit more. So we are improving in this part for a more targeted antibiotic treatment. So we have pros for both. With the NGS, we are able to detect all the bacteria present in the sample. And with the customized panel, we can detect bacteria of the species level, as I mentioned, allowing for more target treatment. And the specific customized panel is based on the experience after analyzing these 70,000 that I mentioned before. And as a cons, we have with the NGS that we cannot determine bacteria at the species level. And with the customized panel, we are going to go for the target ones and missing some of them. But again, we are reaching 98% of the most frequent bacteria. So we do realize that we are improving in changing the technology. And let me show you some global data with these almost 70,000 samples, is that what we have to expect when we perform the first biopsy, and around 25% of the patients will need an antibiotic treatment, and then around 70% of the patients will need a probiotic treatment. Always, when we do recommend to do probiotics, we don't ask for a second biopsy, but always when we do recommend to do antibiotic treatment because we found that there's a pathogen in there, we do recommend antibiotic treatment, then probiotic treatment, and then a second biopsy to be sure that we remove the problem. And the importance also for the second biopsy, in the paper from Dr. Iwami, there was 25% with, again, the same pathogen on another one. With our numbers, we have around 35% of patients that will still having those results. So let's see if changing the technology, we can change these numbers doing a more target antibiotic treatment. And again, this is a recommendation from our side. At the end of the day, you are the physician. You are the ones who decide, okay, I'm going to go for this treatment. I think that this dosage is too low. I can increase it. I have a medical director in Spain that is always telling me, Nasser, you always say this is a low dosage. I give more. So we do a recommendation. We have a microbiological team that is making the recommendation. But then you, as a physician, you can make your call and make your own decision, of course. So just to conclude, I can say that the vagina and endometrial microbiome are quite similar, but also different. In around 20% of the samples we found in endometrium, but not in the vagina. A lactobacilli dominant endometrium is associated with a better reproductive prognosis in IVF patients. Presence of pathogens, I said it before, in endometrium is associated not only with implantation failure and recurrent miscarriage, but also with obstetric problems. The endometrial microbiota composition before the embryo transfer could be a useful biomarker to consider and offering an opportunity for our patients. And with the change of the technology and using a customized target panel, we can detect bacteria species level, allowing for more and better target treatments. And if Hans don't tell me wrong, I think from 1st of November, right, we will be able to start reporting you in this way that we do think that is going to improve all the results that we have. So my last slide is a question for all of you. And I would like to ask you, what is your role as a clinician, as a physician, as an embryologist? Is your role to go ahead, innovation, research? I can see here that yes, this is your role, but I always ask the same, or you want to stay at the present, or you want to go back, like trying to disregard any innovation, like this is a waste of time. Okay, so I would like to thank you for your attention, and please, if you have any questions, let's try to solve it. Thank you very much.
Do you have any data about the type of progesterones that were used for your patients? Like different brands and whether it became, how many of them were receptive and non-receptive? Do you have data on that?
We have data, and we didn't find any difference in between the different ways of administration. What we found is that if you do the mock cycle with one way of administration and you change, the results might change. And this is why we do say that we need to do exactly the same. But so far, as an overall, we didn't see any differences. It's true that for the certain patients, as we observed in one of the cases, it might make a difference because maybe the way of administration is not that good for a certain patient, but as an overall, we didn't find this kind of differences.
Can I make a comment? Well, it seems to me that there are more and more and more things that coming to light that we have to check for patients, and there's no end to it. Would you agree with me that, when you come to all this bacteria and all that? Now, having looked at your slides, you were saying that about 25% of patients will have some abnormalities, some bacteria that we need to change. So 1 in 4 patients will need an antibiotic treatment. So instead of spending money, not to say waste money, spending money on the test, we can easily give empirically everyone some antibiotic treatment, probiotics, and voila, we solve the problem. What's your comment on that?
You know that we have a healthy problem in the world with the use of antibiotics. We are creating resistance. So this would be, for me, like kill flies with a cannon. Let's give everyone's antibiotic so we solve the problem. And I think that we need to personalize. So we need to check in order to know that there is a problem, and then we treat the problem. And as you mentioned, every day we came with something new, but this is because, unfortunately, we are far away of 100% of pregnancy, not even pregnancy, because I said yesterday the same. Patients doesn't want to get pregnant. You know better than me. Patients want to have a healthy baby at home. And we are far away for this 100% that doesn't exist in medicine and biology, but we need to try to reach as above as possible. And we have the PGTA, and then we had the ERA 10 years ago, and we were switching the timing and patients get pregnant, but after several transfer or several patients, some patients has a window of implantation misplaced, you correct, and patient doesn't get pregnant. So this is why we're still looking for more things, and then becomes the microbiome, and then for sure that are coming more things, because again, we are far away of this 100% that we are looking for.
My comment is, to get pregnant, to have an IVF, you will spend X, Y, Z amount of money, and there's no end to it. Yeah. So where do we draw the line?
Well, I'm not saying that. I put an example. It's a colleague of me. It's a medical director of a clinic in North Argentina. And he told me that once he had a case, a patient that came to the clinic, and he looks like her and not well dressed, and thinking she cannot afford a PGTA, so I'm not recommending. He talked about the cycle and everything. 3 weeks later, patient came and said, "Doctor, if I don't have to eat or have a baby, I won't eat. But you must tell me what I need in order to get pregnant, regardless if I have money or I don't have money." And this is why I learned from him and from a neuropediatric from Spain that also showed me that we are not bankers. We do care about our patients, but we must tell them whatever we think that is better. I'm not saying that we need to tell them, oh, you have to do PGTA, ERA, microbiome. No, 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 no. But if your patients need it, even though they cannot afford, we should tell them at least, and then they can decide, oh, like your patient, no, I don't want to go for a second biopsy. I want to go straight on. But we have to put this on the table. We are healthcare. We need to tell them what is better for them, and then they might decide if they want to go for or not.
My question is more a practical question. Is it better to check ERA microbiome testing at the same time or rule out chronic endometritis first, meaning by doing microbiome testing first, then the rest?
I would say that it's better to do it all together. But again, if I have to do something earlier, it would be ERA, because the result is going to be the same this month that in 5 months. Problem with microbiome is that if I do now, it might change in the following cycles. This is why always when we get a normal result, we do recommend to do the transfer in the following cycle. So again, all together would be better. If I have to decide for one of them, first the ERA and then the microbiome test. And something important, because we are always talking about lactobacilli, yes, it's important, but what we are realizing is that it's more important the pathogen that we find in there. So lactobacilli, we do think that it's important because if we have such a high amount of lactobacilli, they are inhibiting another bacteria, cohabitants, to be there, the pathogens. But at the end of the day, I'm pharmacist, my degree. So I do realize that if we have a problem and we treat it and we solve it, then we achieve better results. And this is why I truly believe that the importance in reality is not that much the lactobacilli, but the pathogens that we might find in there, because this 25% is not everything for chronic endometritis. We do have around half of them are because other infections, and we need to treat it. So this is why when somebody asks me, Nasser, should we do only ALIS and not the EMMA? Because you know that the EMMA contains ALIS. I say, I would recommend no, because we will be missing part of the pathogens that are causing infection, but not chronic endometritis specifically.
Can I ask a question about the role of ERA in natural cycle FET as the trend is going towards more of natural cycle FET? Because I have done 1 or 2 ERA on natural cycle FET and getting various kinds of results, and I was told that as the studies all shown, they are all done in HRT cycle. What's the comment about this?
It's true that most of the studies are performed in HRT cycle. At the very beginning, we perform in natural cycle as well, and it works. The thing is that with HRT cycle, we have more control with the patient. But if you perform LH cycle, you measure the peak of the LH, then you can control and you make the biopsy on day 7, and it works. And actually nowadays we are having more cases of this, because you know that the trend now is to go more for the natural cycle than for the HRT, sorry. But again, for us, specifically for the ERA, as far as you have more control on your patient, we prefer the HRT cycle. But LH is perfectly well. I mean, it works, and also the combined with the CGH, giving the shot, and then take 7 days, do the biopsy, and it's exactly the same, even more control than the natural one.
I mean, like, in this part of our world, we can't really find the recommended vaginal probiotics. And another question is like, is the oral probiotic and vaginal probiotic, or can you see that oral probiotic will help to improve the microbiome in the womb?
unfortunately, I don't think that it's a problem from the region, but worldwide. In Spain, for instance, they were like banning the vaginal probiotics, and the patients start using the oral ones. What we do know is that obviously doing vaginal, it's by being closely related with endometrium, they are going to colonize earlier than doing oral. But I think that problem it's going solving step by step. I know that there's a lab in Europe that told me that they lost the vaginal one, but in January next year they want to release one that is approved. So hopefully we are getting this solved. I know that there's a place here for vaginal probiotics, right? We were discussing this yesterday as well because it's a hot topic. We do realize it's not only here, but it happens in Europe, it happens in the States, in Latin America as well.
Yeah, there's a drugstore in JB, which I was told by a Singaporean doctor that they found something there. And I'm also happy to let you know that we are working on it to import something that useful. It's not open yet, but we will work as soon as possible. So yeah, we will show you in the near future. Thank you.
A global problem.
Is there any question more from the floor? For virtual audience, you may use the question panel to send in your question. While waiting for the question from the virtual audience, we have one question from Dr. Nasser. There's a recent development in non-invasive endometrial receptivity testing. Can you explain more how it differs from ERA with the non-invasive of endometrial testing?
Okay, I think that they are asking about the aura test. Okay. I think that the non-invasive test for endometrial receptivity would be great. We are working everyone in medicine with non-invasive tests. We are working in reproductive medicine in NIPT. We are working with analysis of the culture media for chromosomal analysis on the embryo. In oncology, for instance, we are working with biomarkers, taking blood and looking for biomarkers that let us know if we are going to develop or no cancer or the chances to develop cancer. The reality is that I read a little few about it. I mean, I saw that apparently they did a validation study with their test with endometrial. I didn't see any clinical validation so far, but so this is what I have to say, that so far is no, I don't see any validation. Would be great to have something like non-invasive, but let's see, because it's not easy. We all remember about the natural killers, right? That when we were like measuring in the bloodstream, and we do think that it's going to do something, and at the end of the day, after the clinical validation and after the papers, we disregard because it's not useful at all. So we are working also trying to develop endometrial receptivity with a non-invasive way that is taking endometrial fluid, and we do really good. So we are having great results. The problem that we are facing is that looks like it's not that easy as it looks like. So we are having a higher percentage of non-informative results because it's like 5 microliters, even less when you have to take it. So it looks like easy, but it's not that easy. So we are trying to solve this problem because, again, something that is not invasive would be great. And another thing, that if we arrive to the point that taking blood from the patient, we can say the receptivity of the patient. Maybe I think that right now what they are offering is you took blood from all the patients, and in case of implantation failure, you can run the test. Again, I won't do probably this approach like, oh, I want blood from all the patients, because most of them, they are not going to get benefit of this blood drawn. But anyway, this is something that for the future, again, it would be great if we have something like this at the bloodstream that we can say patient is receptive or not. We are working like more than 10 years trying to get something, a device for you at your consultation to measure the patient the day before of the transfer. So far, we are not successful, but we're still working on that. Just not to send a biopsy at the very beginning. You do in your consultation, you measure some biomarkers, and you tell the patient, okay, you are receptive, tomorrow you have transfer. And in case that is not receptive, then next month, you take the biopsy, and let's check if you are pre-receptive or post-receptive. This is working in progress, but let's see when we can have this for you.
I guess that's all for our Q&A. Oh. Okay,
Sorry.
sorry.
Just pose one last question. So as much as we are always been told you mimic the cycle, exactly as it is. So my question is, you have a adenomyotic uterus, you're long down regulated with 2-3 doses of GnRH agonist, and if we have a result that we need to repeat, are you suggesting that we do that 2-3 doses again, or does that not matter? It's only the progestogen administration that matters? What is your advice? Because if you do 3 doses or thin endometrium, you build up and we are asked to repeat the cycle, she's been spending 6 months or 9 months just on testing of this endometrial receptivity, which is kind of not very realistic.
Yeah, what we said is always from the first intake of progesterone and so on. So
the ones that before, it doesn't matter.
it doesn't matter.
And sometimes we do notice that on ERA, they take 10 days of Progynoa, estradiol, they can have the thickness that is required. But on the real cycle, they did not reach that and we extend. So sometimes the patient are so ingrained that, no, doctor, we should follow exact day, same days. So of course we tell them we are actually testing on the progestogen exposure. So that is correct, right?
Yes.
So if we do any other add-ons, sometimes we add on steroids, as you know, we are doing it on RIF patients. So do we mimic everything as it is, like steroids, that some of us give intralipids? Do we do everything same?
Usually, yes, but again, I will ask to our team, because we are aware of certain drugs that it doesn't affect apparently, and another ones that it does affect. But I don't have the control of the cases day by day, but our team does. So maybe I'm telling you, oh, do the same because it's affecting, but they realize that it's not affecting anymore because they analyze more cases. Yeah. So please always check with our ERA team that they will let you know, okay, this you should replicate, this, it doesn't matter.
Sure. So basically the add-ons are steroids, intralipids, and plexin, some of them, or aspirin. These are the 4 ones that we really want to know whether we do the same or it doesn't matter.
Yeah, the thing is that for specific things, we would say just replicate, but again, do the consultation with our team that I will let you know exactly what is the patient having, and then if they have to repeat everything or just few things, or it doesn't matter anything.
Thank you.
You're welcome.